Hi, I'm Colleen Hutchinson, and we are here at the 18th Annual Minimally Invasive Surgery Symposium at the Wynn Encore Las Vegas. I have here with me today Robin Blackstone. Robin, thanks for being here.
Thank you, Colleen. It's great to be here.
Tell us a little bit about yourself?
Sure. I'm Robin Blackstone, and I'm a native of Arizona, and I have been past president of the American Society for Metabolic and Bariatric Surgery, and privileged to be invited to give a talk here at the MISS conference, which is one of my favorite events of the year. And here I am.
So it's one of your favorite events of the year. Why is that?
You know, it's really because, Dr. Shower's foregut and bariatric surgeon, and he has a connection with a lot of people that do really cutting-edge work in this field, and he invites them here to share their work. And the people that come to the conference, I think, are able to take that information and really apply it in their practices in a very pragmatic way. So that combination of kind of expertise, so those of us who do research and who want to know what's going on the cutting edge, we come and we listen to the great speakers that Phil gets here. And then a lot of people are taking away things that they can really use, and that's a very powerful combination.
Yeah. How would you say bariatric surgery has evolved since you served in 2011 as president of ASMBS?
You know, it's light years different.
Yeah.
You know, back when I started working in the field in 2001, the mortality was still 1 in 200 people.
Yeah.
We were only about 50% laparoscopic. We didn't have a lot of very good long-term data on outcomes.
Yeah, no.
There was, safety was still a major concern, as you can see from the mortality rate. And during the 2000s, we really formed a basis of people doing really high quality research, which was a broad group, including many PhDs and medical researchers, so that we could really gather the data to speak to what it was that we were really accomplishing with the surgeries that we did. And now I think the most crucial thing is that we begin to understand these rearrangements of the anatomy in terms of their physiology and signaling. And we understand that some of the things that we thought we were doing are different than what we are doing. That, coupled with really high quality work on behalf of every community surgeon. I mean, the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program contains almost 900 programs, and about 95% of all bariatric surgery is done within those programs. So there's an amazing registry associated with that. There's very high quality data being produced around the country. We're getting back down to the mechanism. I mean, it's vastly different. And now, you know, we can take a patient who's extremely complex and do a bariatric procedure on them, have a major impact on their metabolic disease, get them through it safely with less mortality than a gallbladder.
Yeah, that's amazing.
It's an astonishing story. And I tell you honestly, I have to give so much credit, not only to the leaders of ASMBS and the College of Surgeons and SAGES and everyone who's participated, but really to the community surgeons who have adapted these principles and taken them back and put them into play in their own community hospitals.
Yeah.
And that is really the basis of this success. And patients are benefiting.
Yeah, thank you. Let's get a little clinical. I'd like you to just give us a little bit of an idea of what you're going to be presenting, or maybe some takeaway points on your presentation, which is hypoglycemia in bariatric surgery, or after bariatric surgery.
So, you know, one of the things that we haven't perhaps been as clear in acknowledging is that when we do these operations, we also create a different environment in the patient. And part of that difference is that the body works differently physiologically. So when we began to understand that we operate on a diabetic, the diabetes goes into deep remissions. I think Dr. Adams is going to tell us today that 51% of the people at 12 years that have a gastric bypass don't have diabetes anymore.
Yeah.
And that is really high quality data. So along with that, along with those changes, we create other things.
Yeah.
And the opening our eyes and acknowledging what those things are and how we should work with them is crucial now.
Yeah.
So one of those things is this issue of hypoglycemia. And we'll use the gastric bypass because it's probably the clearest example.
Okay.
We do think probably there's some incidence of this after sleeve, but it's not as well studied. But in general, when we reroute the food stream to come into the small bowel, people have this experience called dumping, which is really just a physiology thing. It's just food going into the small intestine, fluid rushes in, they get palpitations, they get all these kind of symptoms, and then it passes. And usually that can be even right after surgery.
Mm-hmm.
But about 6 months after surgery to a year after, and sometimes many years after, people can begin to experience real symptoms of low blood sugar.
Okay.
And they often at that time are following up with their primary care physicians. And the primary care physicians, and it's this crucial point, educating the primary care community about things like this so that when they see it, they don't spend $1 million chasing things that don't matter. They actually say to themselves, oh, this could be, hypoglycemia, and let's investigate it and let's find out. The incidence of hypoglycemia is probably a lot higher than we thought.
Really?
We originally thought that this, what we call neuroglycopenia, which is kind of the more, severe end of the spectrum, that actually occurred in about 1% of people. It looks like maybe 30% of people are actually affected by some variation of hypoglycemia.
Significant.
Mm-hmm. But the good news is our medical colleagues are right on this. They've introduced antagonist, GLP-1 antagonist, which is very successful in treating even neuroglycopenia, so that hopefully we can treat and mitigate this symptom when it occurs. So I think the really takeaway points are going to be the incidence is higher than we think, that we shouldn't duck it. I was in Iceland on vacation recently, and one of the people on the trip was an internist from New York. She said, you know what, it's so amazing what the results are of gastric bypass. The weight goes down, the diabetes gets better, but I have 2 patients who have unretractable hypoglycemia, and it is incapacitating, and what are you doing about it? And, that's a moment where you can't say, oh, well, it's very low incidence. You've got to say, wow, so what have you done to evaluate them and treat them? And where should you go to get help for that?
Yeah.
And so I think opening our eyes and recognizing that now that we're doing such high numbers of cases, 200,000 a year, and that we're going to have people that have these kinds of downstream complications that really are related to the way the bypass works or the sleeve works, then we have to dig in and we have to deal with that, and we have to collaborate over fixing it.
Yeah.
So I think that's it's an interesting topic. It's very complicated, and it's been fun to get ready for it.
It really underscores the importance of communication with and education for the primary care physician and internists out there, because
And for the patient. Yeah, patients should really be consented to know that this could be a possibility. And when things start to happen to them, they need to know what to do and where to go to get help.
Yeah. We're going to switch gears, and I'd like you to comment on what you see as some challenges that female surgeons face today.
Well,
It's hard.
How long do we have?
I know.
My focus, because I came from private practice and was in private practice most of my career. I've been in academic practice roughly. I've always published and stuff, but I've really been in academic practice for a few years. And now being a professor of surgery and seeing that we have 50% of our residents coming in, many of whom will go into private practice or community practice, employed community practice, I've really become concerned about the skill set that we're teaching them and the level of confidence they're going to have coming out and being in practice. And, I see it in some of my young colleagues around Arizona. And, I think that I think part of the challenge that they face is that we haven't done a lot of formal work with them on conflict resolution, on running committees, getting on committees, like just that piece of teaching, you know, you get privileges at a hospital, you know, what are your next 3 moves? Like,
Yeah.
who do you meet with? What committee do you need? What kind of program planning do you have to do? What should you negotiate before you go there about what kind of support you're going to have?
Yeah.
You know, there's just a lot of these type of skills that honestly, what happens for a lot of our male colleagues is there's a network of people, and when they're brought in, they're directed along this pathway, and when they run into turbulence, somebody's blocking and tackling for that guy.
Yeah.
For women, there's often not such a developed network, although what I've been really encouraged by is that I'm beginning to see mentoring for surgeons that are women by medical physicians, by other women that are in roles where they can mentor.
Yes.
So it doesn't just have to be surgeon to surgeon. It could be, you know, much more broad. But I really think we need a formal way of really teaching this kind of training. And I've been thinking a lot about it for our female residents. How could we do that? And then how could we maybe expand that series of lectures to the community physicians who might want to come? You know, women have a lot to bring to the table. We have, together in groups throughout history, been able to influence and improve our communities, our schools, our family lives, and leveraging that, what I would call deep DNA, in these kind of situations may really, really benefit hospitals and may benefit patients, and I think benefit each other.
Yeah.
You know, when we have a tough outcome, it's hard sometimes to feel that there's anybody that cares. You feel very alone in those moments. What has been interesting lately, because I've been working as a perioperative medical director, is a lot of our male colleagues feel it too.
Really?
You know, there's very little support for us when things go badly. We are called at M&M, we confess our sins, all of that stuff, but honestly, real support, it's almost non-existent. So I think there's a lot of work to do here. Not sure exactly how to approach it, but I'm thinking a lot about it right now. And I really want to try to create something, some way that we can really help our community physicians do their best work and feel supported in doing their best work.
Yes.
So I guess I got a new job.
Well, thank you for those insights and for all the insights you shared today, Robin.
Thank you. Thanks for having me.
You're welcome.